So hello, I'm Christine Peshkin. I'm an associate editor of the Journal of Rheumatology. It's my pleasure to welcome you to this interview featuring the authors of an important article from the November 2025 edition of the Journal of Rheumatology. Today, I'll be speaking with Dr. Justin Smith and Dr. Stephanie Keeling, representing all of the authors of our featured article titled Identifying the State of Mental Health Care in Canadian Adults with Systemic Lupus Erythematosus. Stephanie and Justin, thank you for taking the time to speak with me.
Thanks for having us.
So much.
Great. So I'll start off by asking you if you can give us an overview of the rationale for this study. What prompted you to look at this area of research?
So that's a great question. And we know that compared to the general population, mental health challenges such as depression, anxiety, cognitive symptoms are highly prevalent in patients living with lupus. Yet clinically, a lot of times, I can speak for myself, a lot of times we don't know how to address these concerns, or once they're addressed, how to actually manage them. And this project actually came up when I was a internal medicine resident working with Dr. Keeling in her clinic. And clinically, back to back, we saw multiple patients in a row where we had this clinical question. And so that's where we actually came up with this initial clinical question and study.
Yeah,
Great.
I can also attest that I think we've had experience, at least in the past year. I've had one of my lupus patients, unfortunately, commit suicide, and there was a lot of issues with access to any supportive mental health care. So I think that really struck home the work that Justin was already doing to sort of show that how significant the need is.
So what was the aim then of this study?
So I think the aim was mainly to determine what the current state of mental health care access is in Canada, specifically for physicians treating patients with lupus. Um, we wanted to address and identify the barriers and gaps, but also what's being done right now by physicians, and then also what potential supports or interventions could be available, either as addressed by the patients or as addressed by the providers.
Can you go over the methodology for the study?
Of course. So it was a pretty simple study. It was a survey-based study. It was available to patients with self-identified lupus throughout Canada. So we had it mainly sent to patients through Lupus Canada social media, so through Instagram, Facebook, as well as newsletters. And then in terms of the rheumatologists and their survey, because we're in Alberta, we initially started with an Alberta-wide survey, but then we also had the survey sent to members of Canios. And so we actually had a decent spread across Canada in terms of physicians that way. We also did, it was mostly survey-based, but we did have some questions at the end of the survey for more of a qualitative look. We didn't actually analyze this or publish this, but it was very interesting to see the answers because many patients actually answered these questions, just essentially, what else do you have to say about this subject? And it was very enlightening to see what patients and physicians had to say about the subject.
So then what were the main barriers to mental health care access that you identified, and what were the interventions that were identified as most important by participants in the survey?
So I think the barriers that we identified were really no surprise to us. And we saw that it ranged from structural issues to systemic issues to more personal issues. So in terms of physicians, obviously it was things like time constraints, wait times for access to mental health care, and then also just lack of standardized referral systems. A lot of physicians just didn't know where they could send patients if they needed access quickly. And then in terms of patients, they also identified wait times as a major issue. But unlike what the physicians identified, patients actually noted issues with affordability, whether that was paying out of pocket or lack of insurance. And I think sometimes, we obviously deal with that with our medications, but we may not think about it in terms of other ways to access healthcare. And then interestingly, there were some, I guess, levels of discomfort discussing mental health care, both with the rheumatologist and with their primary care physician. And also just the word stigma was brought up, which interestingly, physicians did not think that stigma was an issue discussing these concerns with patients, but patients did still feel that there may be a stigma associated with this. In terms of the interventions, so we had a long list of interventions that patients and physicians could rate on a Likert scale for which they thought would be most useful. In terms of the interventions patients thought were more useful, mental health services actually integrated into the rheumatology clinic was number one, and then screening in the primary care physician office, and then followed that screening in the rheumatologist office. So they actually wanted direct mental health care available to them when they see their rheumatologist, which was interesting because, well, on the flip side, the rheumatologists that we did survey, they did want access to referral systems or access to timely mental health care access. But the lowest rated intervention was actually standardized screening within the within the rheumatology clinic. So there is this disconnect that we identified between patient and physician. And I think that's very important going forward when we talk about potential next steps.
Yeah, I was going to add that I think in general in rheumatology clinics now, particularly the lupus space, like increasingly more, there will be more potentially medications, which is exciting. But we know we're also doing other things already, or trying to, like primary prevention, cardiovascular stuff. So then adding another layer, the pressure to somehow find a method in your clinic to find time to do some form of screening. Is problematic, and yet that disconnect is interesting with what patient preference to what physician preference, right? They're sort of disparate. So I think it really speaks to, yeah, how do we go forward with this, which I'm sure is probably your next question. But before, I think if we're taking this to different provinces, and maybe if others in other countries are looking at this, every healthcare system is different and regional, but there's got to be a way to first see what the problem is, which is what I think Justin has tried to demonstrate here in metrics that stakeholders like government who might support changes in how we deliver this type of intervention may go forward.
Yeah, and yes, I was going to ask about that, because you did raise the possibility of the standardized mental health screening in clinics, and I did wonder about the feasibility for the exact reasons that you've just stated. But given, just to, since you've answered that, given the patient preference for integrated mental health services, other disciplines, have recognized this, and some of our colleagues, whether it's renal health or other disciplines, have embedded social work or others as a routine in clinic. And I'm wondering if, again, you mentioned policymakers, whether we could raise the awareness because that might alleviate pressure on primary care and rheumatology, but satisfy the patient request for integrated mental health care. It's a bit of a dream.
Yeah, I agree. I think that if anything, this identifies that rheumatologists and family physicians cannot do this alone. And I think that there's a great need for allied healthcare access, whether it's for mental health care or other screening that we theoretically should be doing in our patients. We have 20, 30, 40-minute appointments. And if a patient's lupus is flaring or they have questions about their medications, I think oftentimes we think that those are the most important things to address, which, probably are for what we're seeing. However, I think patients have identified here that, numbers and exam findings, maybe that's not what they care about the most. Perhaps it's actually the quality of life and feeling like they're a person behind their disease. And so there is that fine balance, though, because I think as physicians, we also have to address, okay, well, what is most important at the time that we're seeing the patient? But in the end, I think a lot of models are moving to a more holistic level of care, and hopefully we can strive for that as well.
Yeah. I mean, yeah, yesterday I had somebody in clinic who came back after a 5-year hiatus from seeing doctors because she had so much depression that she just stopped going, stops her drugs. So even though she's in a flare, if she's not well enough to have the insight to be able to do that, the rest doesn't work, right? I mean, that just struck home to me, this whole situation that we're sort of talking about in Justin's study.
Yeah, and we know for sure that high levels of depression, high levels of anxiety actually lead to poor outcomes in terms of medication adherence, and specifically to lupus, higher SLEDI scores. And so it is something that I think needs to be addressed, whether that's just a marker of disease activity or whether it's a marker of what's actually going on in their life. I think it's still important.
Yeah,
For sure. I also did wonder, I mean, I noticed that the majority of the patient participants were urban and white. And, it was a large chunk of participants, but do you think that the barriers and concerns would be similar for patients from other ethnic backgrounds or more rural regions, or what do you think it would be different?
Yeah, Stephanie and I were discussing this point, and definitely we did see more patients that I identified as white or lived in urban settings. And this is a limitation, obviously, to survey-based studies as we select for patients that are actually following Lupus Canada or are interested in this subject. We were actually wondering perhaps our results could be an underrepresentation of mental health concerns because perhaps patients that are living in more urban settings or white, theoretically, there could be a higher socioeconomic status associated with that. And we know that patients from lower SES groups or diversified ethnic groups, there is a difference in culture in terms of discussing mental health care. There are different stressors and barriers that they I imagine that they would report. So maybe we're not getting the full scope of what the barriers are, but I actually wonder if the concerns are underrepresented, given that we only, well, not only, but we had a significantly white group of respondents.
I just also want to take you up on, you mentioned that you have a lot of very interesting qualitative data that's not included in this paper. Are you intending to analyze that and publish it?
It's a good question. As of as of now, no. But we might actually be able to use it going forward in terms of next steps, because one of the things that I would like to do in our lupus clinic is potentially look into a pilot standardized screening process, which has already been done in the pediatric population, specifically in Toronto at Sick Kids. And so I would like to try to do that in our own clinic. And I think, obviously there are pearls and pitfalls that you can learn from these experiences, but perhaps using qualitative data that we get from this study, as well as from an ongoing or future study, that could actually help leverage different stakeholders, policymakers, to help us move things forward. And so, in writing grant applications and trying to fund this project, I think that actually using that qualitative data might be helpful.
Great. Thank you. Was there anything else you wanted to add that we might have missed?
I mean, from my perspective, in reviewing the literature surrounding this area and seeing what patients say qualitatively, and then also just seeing what was seen in the survey, it really underscores how deeply intertwined mental health and lupus are, and how, oftentimes disease activity can portray lower mental health in terms of, I guess, depression, anxiety, but also how patients want these things addressed because it makes them feel like they are a person underneath their disease. And I think that actually does portend a stronger relationship with the rheumatologist, furthermore, then hopefully stronger or higher levels of medication adherence and then better disease control. So, I think it's a fine balance between addressing all of these things in our clinics, but based on what we've seen, I think it's what patients do want, and we have to find a way to make it work for us as well, because in the end, we're the ones that are providing the care and working with the patients.
And I would just add to a step further. I think we all know this goes beyond just the lupus patient too, right? Like we probably are seeing the impact of mental health in multiple disease domains, like rheumatology and outside of rheumatology, whether you're talking about like neurology, like multiple sclerosis patients with chronic disease, IBD patients, our other like chronic pain patients, and like some of the ones with like more severe also connective tissue disease like scleroderma. So I think the modeling here and the potential for interventions could in theory be applied, across different domains as well.
Great. Well, thank you then once again for discussing the findings of this paper. And to our viewers and listeners, please read the article titled Identifying the State of Mental Health Care in Canadian Adults with Systemic Lupus Erythematosus. It's available on the journal's website at jroom.org and will also be featured in the November print edition. Thanks for joining us, and we look forward to having you with us next month for another featured paper from the Journal of Rheumatology.